the presentation.
Sure.
Okay, I think we're going to wait just a minute or two for others to join. Welcome, everyone. We'll just wait 1 or 2 more minutes while others join. Thank you. Okay. 1 more minute and then we'll kick off. Thank you. Welcome, everyone. Okay. Welcome, everyone, to this webinar on innovations for equity-oriented health service delivery in rural and remote areas. This is actually the 8th webinar in our series on rural health equity. And my name is Theodora Swift-Kohler, and I lead the health equity work under the Gender Equity and Human Rights team in the Director General's office here in WHO headquarters. And I'll be your chair today. Next slide, please. Next. So just to say a bit about the series for those who are joining for the first time, this is as I mentioned, 8-part series spanning July 2021 to March 2022. And it's been convened under the umbrella of World Health Day 2021, which focused on health equity. In addition, it's a satellite series to the 18th World Rural Health Conference 2021. And also it's linking to activities being convened by the UN, the wider UN, on rural inequalities, specifically the activities of the rural inequalities subgroup under the Inequalities Task Team across UN levels. Next slide. So today's focus is on innovation. So innovation linked to technology, linked to service delivery, linked to organization. And I just want to quote our Director General, specifically on WHO's approach to innovation. The WHO Innovation and Health approach is our commitment to work in new ways with our member states, workforce, and partners, and leverage our respective strengths to find the most impactful, innovative solutions and bring them to the people that need them the most. Join us and let's get to work. So today what we're doing is honing in on innovations specifically for rural populations. Next slide, please. And we are very honored to have with us a great set of panelists today. Our first will be Dr. Enkasaikan Lakhagvasuren, who is coming from the Ministry of Health in Mongolia, together with Gamba Biamba, who's from our WHO country office for Mongolia. We're also joined by Derek Munin, who's unit head here in HQ for capacity building and collaboration, digital health and innovation, as well as Stuart Keel, who's working in the disability and rehabilitation department here at HQ as well. Then we'll have some final closing words from our great partners in this series, the World Organization of Family Doctors, Working Party on Rural Practice, and Bruce Charter, the chair of that, will be giving some closing remarks. Next slide, please. So I'd like to now kick us off on the panel. I'd like to please ask Dr. Enkasaikan Lakhagvasuren to get ready to present together with Gamba Biamba. And so Dr. Lakhagvasuren is Director of the Division for Infectious Diseases in the Ministry of Health of Mongolia. She was previously a lecturer in the Department of Immunology, School of Biomedicine, Mongolian National University of Medical Sciences until March 2021. Dr. Gamba Biamba is a program officer in the WHO country office for Mongolia since 2016. He has been working for the WHO country office in the areas of universal health coverage, primary health care, health technology assessment, gender equity and human rights, and health futures strategic dialogues. As part of the campaign to celebrate World Health Day 2021, focusing on health equity, the Ministry of Health and the WHO Mongolia country office launched a competitive project for health equity champions among family, SOM, and village health centers. The competition aimed to position communities at the forefront and health equity as a key priority in fulfilling the commitments to achieve universal health coverage and the SDGs, and to identify and address socioeconomic drivers of health inequities and health challenges experienced by communities. Today, the presentation and the video will focus on the organizational and social innovations through the Health Equity Champions Project in Mongolia to decrease health inequities and barriers to services in rural areas. So with that, I'd like to please now hand over to Dr. Lakhagvasuren, who's going to open with some slides before introducing the video. Thank you. Over to you.
Thank you. Thank you very much for your nice introduction. In 2021, WHO announced the World Health Day focused on health equity. So next slide. So together with the WHO country office, Ministry of Health of Mongolia launched a nationwide competition among the public health providers on health equity champions. So 54 prizes were received and 10 of them selected. Next slide. And you can see the geographical regions of these 10 proposals. Next slide, please. So you can see the list of the selected provinces, family health centers. Next slide, please. So our target group was non-registered people, non-insured people, remote area herders, border guards and their family, and also we are focused on the mobile population and disability peoples. Next slide, please. So the action plans which derive from centers focused on solution of real needs of the target population based on the health equity lens, including health vaccination for non-registered, non-insured mobile population, COVID vaccination for target groups, mobile ambulatory services, and home visits supported by intersectoral collaborations, developed an application for target group to reach to unreached and provided health services information and improved health education. Next slide, please. So you can see here some pictures of the selected family health centers, which some belong Hubskull, Opus, and Dalnut, and in here in Biohunger, parents and caregivers of 300 children received information about public health centers, family health centers. So primary health care is very important in Mongolia. Next slide, please. So we concluded here, so needs assessment at local needs. So all projects based on local needs and aimed at better solutions. So intersectoral cooperation to address influence issues facing vulnerable groups, and we improved. So geographical barriers, lack of information and educational health issues, and we are focused on unregistered and the insured problems were addressed. So access and quality to health services, especially among touched groups, and based on the needs assessment, this public health providers delivered health services using technology, mobile applications. So awarenesses and attitude of family group practitioners on genders and human rights and public health centers is improved. So I think this project was very important and helpful in Mongolia. So Ministry of Health of Mongolia is very thankful for WHO. Thank you very much. Over to you.
Thank you so much. And so now we have the honor of seeing one of the videos, actually, that was produced based on the one of the winning centers, health centers, through this competition project for health equity champions. Please, can you go ahead and show it, Pamela? Thank you.
Эрүүл мэндийн тэгш байдлын мандайлагчид төсөл үзүүлж байна. Дорнод аймгийн Баян улс сум 1924 онд улс хурлын эрхт анхлан байгуулагдсан Дорнод аймгийн анхны сумын нэг юм. Засаг захиргаа нэгжийн хувьд 6 багт харьяалагддаг 562.2 мянган га газар нутагт Монголын ойд хэрийн бүсэд Хинтийн уулархаг нутгийн зүүн хойд хэсэгт оршин зүүн болон өмнөд хэсгэрийн өөрийн аймгийн Баян дулсум цагаан овоо баруун ба баруун хойд хэсгэрийн Хинтийн аймгийн Нурвлан Дадал сум хойд хэсгэрийн Оросын холбооны улсын Читамужтай хил залхуу оршдог юм. Аймгийн төвөөс 200 км алслагдсан хилийн сум юм.
Тэгэхээр манай сум 5000 гаруй хүн амтай, үүнээс дээр нэмэгдээд 200 гаруй бүртгүүлгүй иргэд байдаг. Энэ нь ямар учиртай юм гэхээр юуны гадны малчид болон хилийн цэргийн анги тэд онцгой байдлын ангид ирсэн тэд албан хаагчид мөн тэдний гэр бүлийнхэн байдаг. Эдгээр болохоор манай суманд бүртгүүлгүй учраас эрүүл мэндийн тусламж үйлчилгээг оройтож авдаг. Ялангуяа хүүхэд өндөр настан жирэмсэнгүүд нь эрүүл мэндийн тусламж үйлчилгээг оройтож авдаг гэсэн судалгаа сүүлийн 3 жилээр харахад бол ийм судалгаа гарсан юм.
Сумын хэмжээнд онцлог үйл ажиллагаа хилийн цэргийн нэг анги, онцгой байдлын анги, ер нь бүс нутгийн хэмжээнд бол манай сумдынхаа хэмжээнд нэлээд сумхан сумуудын нэг үл болж явдаг.
Яг манай суманд ирээд 10 жил болсон ч гэлээ гэсэн өөрөө ямар ч тийм бүртгүүлгүй хүн одоо энэ жишээлбэл ковидын вакциныг хамруулах гэхээр хамрагдаж болохгүй нөгөө юу байхгүй. Регистрээ өөрөө мэддэг тэрнгөөр нь ингээд янгууд улсын бүртгэл байхгүй. Ийм хүмүүс бол манайд бол 2 3 байна. Ковидынхаа вакцинд хамруулж чадахгүй өөр ямар ч үзлэг хамруулж чадахгүй нэг ийм нэг хүндрэлтэй тал байгаад байгаа маа бид нарт.
Холбогдлын хувьд бол маш холбогдолтой төсөл. Энэ маань яг одоо тэгэхээр манай сумын хэмжээнд би дөрөнд өрсөн тийм ээ. Хилийн цэрэг байна, онцгой байдлын анги салбарууд байж байна. Мөн дээрээс нь одоо хотор нөдлөөр ирж байгаа иргэд төр оршин суугаа иргэд бүртгэлгүй иргэд байгаатай холбоотой. Энэ маань одоо төрийн үйлчлэгийг авч чаддаггүй нэг мөн дээрээс нь эрүүл мэндийн үйлчлэгийг хөрөлцөө дутмаг байдаг бүртгэлгүйгээс хамрагдаж чаддаггүй нэг юм зүйлүүд байдаг.
Нийт иргэдийн 80 орчим хувь нь буряд яс үндэстэн голчлон амьдардаг. Дорнод аймгийн ой нөөцийн 80 орчим хувь тус суманд байдаг. Мөн Оросын холбооны улс дахь уйлхан хилийн бомб болон олон улсын чанартай замтай болохоор цаашдаа бүс нутгийн зангилаа төв болох боломжтой.
Төслийнхөө хүрээнд 82 өрхийн 174 хүнийг бүртгэлжүүлж тэдэндээ эрүүл мэндийн анхан шатны тусламж үйлчилгээ үзүүлж урьдчилан сэргийлэх үзлэг болон шинжилгээнүүдийг хийсэн байгаа. Энэ шинжилгээндээ бид энэ эхо онцлогооны аппарат, явуулын эхо онцлогооны аппарат, мөн энэ зүрхний бичлэгийн аппарат энтрийг иймэрхүү юмнуудад ашигласан. Тэгээд мөн цусны шинжилгээ. Тэгээд цусны шинжилгээгээр бид нар юу илрүүлсэн гэхээр доох эдийн замын өвчин, холестерин илрүүлэх, БЦ вирус илрүүлэх гэсэн ийм онцлогоонуудыг бас хийж авсан байгаа.
Манай сумч нь болохоор Дорнод аймгийнхаа хэмжээнд хамгийн олон хүн амтай, хөдөлгөөнд хүн ам бол олонтой, бүртгэлгүй энэ хүмүүс маань ихэнх нь ерөн манай суманд ирээд 4-5 жил бүртгэл судалгаанд хамагдаагүй ингээд төр байдгийн билээ.
Өвчин зовлон өрөөд одоо имлэг домдоор очиход тэгэл юу байхгүй бүртгэлгүй судалгаагүй багтаа харьяалагддаг л одоо жишээ нь үзүүлэхэд хүндрэлтэй гэдгийсэн. Тэгээ манай энэ сумын имлэгч нь болонгод байнгын нөгөө дуудлага вакцин энэ ерөн ковид гарснаас хойш аюул сайн тийм байнга ерөн явж тайраа вакцина хийгээд ерөн үйлчилгээ сайдаа манайхаа хамтран ажилладаг болохоор манд ерөн аягүй тийм ойр байдаг шүү дээ. Ковидын эсрэг дархлаажуулалтанд хамрагдаагүй байсан нэг эсвэл нэгэ хийлгсэн эсвэл хоёроо хийлгээд ингээд 3 дахь тундаа энэ хамрагдаагүй байсан хүмүүсээ бол нийт 54 хүнийг бол энэ ковид цар тахлын эсрэг вакцинд бол хамруулсан байгаа. 2-3 дугаар тунд нь хамруулсан байгаа. Зарим нэг хүнд бол бүр 1-р тун анхныхан тун хийсэн байгаа. Эднэр бол хийгдээгүй байсан хүмүүс нь байсан. За тэгээд мөн энэ илэр хүмүүсээс 2-5 насны хүүхдүүдийн 12 хүүхдүүд бол томоогийн эсрэг вакцинд бол хамруулсан.
Энэ төсөл хэрэгжснээр бол одоо эдгээр иргэд маань төрийн үйлчилгээг авах мөн одоо энэ халдвар цар тахлын үед бол эрүүл мэндийн бол онцгойлон одоо эрүүл мэндийн дэмжлэг тусалцаа авах юм сайн төсөл гэж бүхэн бол үзэж байна.
За тэгээд хэлжид бүхэн нэг 3-4 жил ажиллаад ингээд шилжээ явдаг. Тэгээд энэ бүхэн дээр бас эрүүл мэндийн одоо байгууллагуудад бүртгүүлэхээс хүсвэл хүндрэл ачаал маш их гардаг. Тэгээд ялангуяа энэ цар тахлын үед одоо хамгийн түрүү одоо гэр бүлэрээ ирээд хүүхдүүдэд вакцинжуулахаас хүсвэл бүртгэлд хамгийн түрүү одоо хамрагдах зүйл бол эрүүл мэндийн байгууллага байдаг.
Тэгэхээр илрүүлэг үзэлгээр мөн бид нар 2 жирэмснийг илрүүлсэн байгаа. Тэрнээс нэг нь бол ихэр жирэмсэн байсан. Энэ нь болохоор энэ явуулын яхаа үзэлгээр ингээд бид нар жирэмсэнгүүдээ илрүүлсэн, бага сартай жирэмсэнгүүдээ илрүүлж ажилласан байгаа. Тэгээд
за хэлийн стафт амьдарч байгаа албаагчид маань сумын эрүүл мэндийн төвөөсөө зайтай одоо жишээ нь хамгийн ойрхон л гэхэд нэг 50-60 км-ийн зайтай амьдардаг албаагчид маань эмнэлгийн тусламж үйлчилгээ авахд хүндрэлтэй байдаг. За нэг хэлийн салбар дээр янз бүрийн гэмтэл бэртэл авлаа гэхэд дуудлагын төргөн тусламжийн дуудлага ирэхэд цаг алдах тийм хүндрэлтэй асуудлууд мөн хүүхдээ багчуудаа нөгөө вакцинд хамруулах өөртөө нарийн мэргэжлийн эмч болон үзлэг шинжилгээ онцлогоонд хамруулахад заавалчгүй нэг 100 км ч юм уу 40-50 км-ийн зайд очиж эмнэлгийн тусламж үйлчилгээ авах цаг алдах тийм асуудлууд ер нь тулгардаг л да. Тэгээд хэлийн салбарт одоо яг харьяалалгүй энэ тентхийн орон нутгаас ирсэн амьдарч байгаа албаагчид ер нь голцох төлхөө байдаг болохоор ер нь бол тэн дээр жоохон хэлийн салбарын албаагчид маань асуудал эрүүл мэндийн тусламж үйлчилгээ авах жоохон хүндрэлтэй талууд гардаг.
Манай хамгийн хол нь болохоор 84 км-т байгаа. Баян хонгор аймгаас ирсэн иргэд бол ерөөсө бүртгэлгүй маш олон иргэд байсан. Ихэнх нь бол тэр Баян хонгор аймгаас ирсэн малчид байсан. Тэгээд тэд нар болохоор эсвэл нөгөө Баян уулын зааг, Баян уул, Баян цагаан овоогийн нутгийн зааг дээр эсвэл Баян уул Хинтээ аймгийн Норуулан сумын зааг дээр байсан ийм хүмүүс байсан байгаа.
Федраас Баян уул дээрээ одоо ингээд 3-4 жил болж байна. Тэгээд энд бид стафт одоо нөхөртөөгөө амьдарч байгаа. Тэгээд бас эмнэлгийн үйл ажиллагаа ингээд авах айгүй хэцүү хүндрэлтэй байдаг учраас тэгээд аль болох нь тэр болгон сум орч чадахгүй тэгээд тийм байдаг болохоор тэгээд одоо энд доронтоос ингээд эмчнэр ингээд сар болгоо ирж ингээд бид нарыг үзэж ингээд хүүхдүүдийн маань үзэж тэгээд ингээд сар болгоо ирж үзэхэд нь бид нэр амар баярлдаг.
Ковид цар тахлын үед бас юу дархлаагийн дэмжих зорилгоор ийм юу доктор, шар доктор гэсэн энэ шүүс тэгээд энэ вириш гэдэг энэ дархлаа дэмждэг тусал тэгээ ирээвит гэсэн ийм битмийн хөгж ажилласан байгаа гэдэг.
Энэ Дорнод аймгийн Баян улс сүмд ирээд жил болж байна. Эмнэлгийн үйлчлэгээ бол маш сайн биднийг бол маш сайн хүлээж авч биднийг бүрэн үйлчлэгээр хангадаг үздэг.
Энэ төслийн хүрээнд 82 өрхийн 174 иргэнийг эрүүл мэндийн тусламж үйлчилгээнд хамруулан ажилласаар үүнээс илэрсэн өрчлөлт 24 байлаа. Өрчлөлийн байдлаар авч үзэх бол зүрх судасны тогтолцооны өрчлөлт 13, хоол боловсруулах эрхтний өрчлөлт 3, шийдвэр бэлгийн замын өрчлөлт 2, мэдрэлийн тогтолцооны өрчлөлт 2, яс булчингийн тогтолцооны өрчлөлт 3, мөн хөгжлийн бүсэлчтэй 2 иргэн хамрагдсан байна. За 2-оос 5 насны 12 хүүхдийг томоогийн багцанд хамруулсан 31 хүүхдийг цагаан хурхын шинжилгээнд хамруулахад 2 хүүхэд цагаан хурхайтай илэрсэн. Үүнийг эмээр эмчлэн өргөжүүлсэн. Манай суманд ковидын тархалт их байгаа үед манай эмдэг ногоон улаан бусгаж 2 хуваалдан ажиллаж байсан. Өвчтөн хөлтөн эмчилгэхэд одоо ор хүрдэхгүй байсан учраас буудлын нэг өрөөг түрээслэн ажиллаж эдгээр өвчтнүүдийг эмчлэн өргөжүүлж хяналтандаа хамруулсан. Төсөл хэрэгжсэнээс бид нөгөө бүртгэлгүй иргэдэг бүртгэлтэй болгоод цаашид тэдэнд эрүүл мэндийн анхан шатны тусламжаа хүргэн тэгэд эдгээр иргэд мань хаашаа нөөж шилжиж явсан гэснийг нь мэдээлэлтэй болж ажилласанд нь нэрийн нэг ажлын үр дүн юм болов уу гэж бодож байгаа. Ер нь бол одоо яг ковид энэ төслийн хэрэгжиж ковидын одоо тархалтай давхсан учраас бол ер нь жоохон хүндрэл байсан. Одоо тухайн хүмүүс доошиж өөрчлөх эмнэлэг 2 хуваагдсан учраас хүн хөрөлцөхгүй байх ер нь тухайн үед жоохон хүндрэл байсан. Гэхдээ одоо ямар ч энэ төслийг одоо хэрэгжүүлж бүртгэлгүй иргэдийг бүртгэлтэй болгож чадсан. Тийм учраас бол сэтгэл хангалуун байгаа энэ төслийн хүрээнд бол.
За сумын хэмжээнд бол гаднаас содор нүүдэл хийж байгаа 10 гаруй өрх байна. Эндийн хувьд бол за элийн цэргийн ингээд хувьд бол бас нэлээд би бас 2 зас тав дээр бол иргэд бол бүртгэлгүйгээр одоо оршиж сууж бол арга ирээд байгаа зүйл амьдарч байгаа. Энэ дээр бол мэдээ хүн бол баярлах эрүүл мэндийн үйлчлэгээр хөрвөх чиглэлээр бол ажилладаг. Гэсэн гэдэш усан зардалтай холбоотой эрүүл мэндийн ажлын хөгжөлтэй холбоотой төдийлөн бас явж чадахгүй байх асуудлууд бол гардаг. Энэ төслийн хүрээнд бол бас энэ иргэдэд хурц ажиллах нь сайн талтай гэж үзэж байгаа.
Thank you so much for that great presentation and the video. I see some questions coming in the chat, and I would like to say, please do continue to put any questions there. And what we're going to do is go through with the other speakers in the panel, and then we'll have a dedicated Q&A time. Okay, so really that was a great example of really work to understand local needs, understand the barriers that certain subpopulations may be experiencing, such as those who are unregistered, and then defining very targeted interventions to close those coverage gaps, to overcome those barriers. And I think that the example that you've given and that you've shared for Dorad, focusing on populations that are not registered, it really is is applicable globally. A very, very important issue why rural populations in particular, and those who are mobile, whether it's because of their herder lifestyle or other factors like, moving from one province to the next. I think this is a key issue to look at globally as to why some rural populations don't get access. So with that, I'd like to now go to our next speaker in the panel, and this is Derek Munin. He's head of the Digital Health Capacity Building and Collaboration Unit of the Digital Health and Innovation Department at WHO headquarters. He previously worked at the WHO AFRO as, our Regional Office for Africa as eHealth and mHealth Regional Advisor. Previously, he worked with the US Centers for Disease Control and Prevention as Health Information Systems Applications Development Manager. He is currently serving as the Acting Director for the Digital Health and Innovation Department at WHO headquarters. His presentation will focus on the use of digital health to reduce inequalities and access to improve the quality of service delivery capacity in rural areas. The presentation will use the WHO Global Strategy on Digital Health as a backdrop and use of specific digital health products such as telemedicine, digital health adaptation kits, and mHealth products. So over to you, Derek, and it's a pleasure to have you with us. Thank you.
Thank you very much, Theodora. Just checking if you can hear me all right.
Yes, we can hear you well. Thank you.
Thank you so much for inviting us here. And dear viewers, good morning, afternoon, or evening, depending on where you are. It's my pleasure to continue the discussions on this panel around the topic of digital health within the context of how digital health is an enabler in minimizing health inequalities and at the same time as an enabler of access to health services and access to people that may be marginalized, especially people in rural areas. As has been mentioned, what I'll really focus upon is looking at the opportunities of digital health services to really reach people in remote areas who, by virtue of location, are usually left behind. And in universal health coverage areas, we like to say, leave no one behind. In digital health, we also like to say, leave no one offline. I'll kick off by making some reflections as follows. We know that the COVID-19 pandemic has created an opportunity for the amplification of digital health to services and applications, and has amplified more now than ever the apparent viable, scalable, and flexible alternatives that digital health programs and products provide. We also know that digital health, well implemented at scale, has opportunity to accelerate health equity by making health systems more robust, resilient, and scalable. At the same time, we know that there are specific digital health interventions, products, and services, such as remote monitoring services, which I'll speak to in greater detail, and telemedicine facilities that have potential to reach people in hard-to-reach areas, such as rural places. And at the same time, we know that there's tremendous opportunity today, given the increase or proliferation of mobile technologies out there, for us to be able to expand the reach of digital health interventions to people that would have otherwise not be reached without this opportunity of mobile connectivity. However, we should also recognize that there are still challenges and hurdles that we need to address, such as the issue around being able to identify fit-for-purpose digital solutions that are fit for remote areas, for example, and rural areas, solutions that are adaptable, scalable, and also resilient, solutions that are usable by people wherever they are, irrespective of their educational literacy. And so issues around addressing data quality, addressing digital literacy, and also taking into account privacy needs, especially when implementing digital solutions across a network, are key. We have learned from statistics from the ITU that there are still gaps that the ecosystem of digital health needs to address. Issues around connectivity, access to the internet, the availability of broadband. Globally, 72% of households, according to the ITU, in urban areas have access to the internet. And we see more and more deployment of fiber networks in urban areas. We see more and more increased access to broadband. However, the opposite situation is true when it comes to rural populations, where 38% of those populations are covered by broadband. So connectivity gaps in rural areas, especially in least development countries, where 17% of the rural population live in areas with no mobile coverage, are at a disadvantage when digital solutions exist that do not depend upon connectivity. And 19% of the rural populations are only covered by 2G network connectivity. However, there is an opportunity that we have to leverage to ensure that we minimize the gap of access to health services by using tested, scalable, sustainable digital solutions. And we have seen over the years an increase in innovation by our partners, including innovations that bring telehealth services to people in rural areas, innovations that bring access to digital products without the need to have access to a connected environment. And at WHO, we have been leveraging such technologies, such as mHealth technologies, that take advantage of those devices that people in rural areas have access to, such as feature phones and other modalities. Now, I'd like to step back to frame the approach that we as WHO are taking to ensure that we have a holistic approach, a sustainable approach, where in as far as implementing digital health programs and products are concerned. The storyline that is before you starts all the way from 2005, where it was recognized that the use of ICTs in health is critical for us to advance universal health coverage, for us to reach the people in rural populations, for us to really accelerate the targets that have been globally agreed, such as the SDGs. And with this agreement that our member states provided us came the need to address standards for data exchange, especially when digital systems are being used at a distance, such as in telemedicine or in electronic record keeping. These two resolutions of 2005 and 2013 have been critical to address the need of access, to address the need of scalability, and also to address the need of data exchange. Today, the organization is focused upon amplifying the digital health resolution that combines mHealth resolutions and e-health resolutions into one comprehensive, coherent resolution called the digital health resolution, upon which we have built a strategy to actualize the resolution in pursuit of what we call the triple billion targets and the SDGs. This strategy that I just talked about is critical in as far as making sure that we have equitable access to health services through digital health. And I'll talk about the strategy a bit more. So in terms of the general vision of the strategy is to improve health for everyone, everywhere, urban or rural, without distinction, by accelerating the development and adoption of appropriate digital health solutions to achieve the health-related SDGs. And within this vision is the aspiration for us to ensure that we're leveraging access to health services using digital, improving health outcomes by means of tested, curated digital health products, and making sure that those that are off the grid, that have no access to broadband, to connectivity, are able to have some form of digital implementations that transfer health content and health messages accessible within a container. In this particular container would be a device that does not need to depend upon a connected environment. So our vision really, in terms of the global approach on digitalization, is universal health coverage, reaching everyone and making sure that we leave no one behind. And in terms of the 4 pillars of the strategy, includes the issue of collaboration and also making sure that we are appropriately putting in mechanisms to transfer know-how and knowledge to our member states. And then secondly, to ensure that countries are able to develop, maintain, and scale strategies that are equitable, strategies of digital health that are equitable, that take into account people in remote places, in rural areas, and also in urban areas. And then third pillar really is all about governance. And so digital solutions have been implemented for the past few decades. And some have shown progress in terms of maturing to scale, and others have remained in pilot. And so this 4th pillar is intended to ensure that there's appropriate governance to amplify those digital solutions that are working, and also to refocus those digital solutions that are stagnating because of lack of scalability. And then lastly, pillar 4, which is extremely important for our conversation today, the aspect of people centricity, leaving no one behind, universal health coverage, and also making sure that we are focusing on the needs of people where they are, taking into account the capabilities that people have. And here I'm speaking about digital literacy. And so what we're dealing with here is making sure that in as much as we're deploying digital solutions, we are also at the same time making sure that the recipient of services via digital, or at least expected recipients of digital services or health services via digital modalities, are digitally capable to interact. And so the subject of digital literacy is important because it's one thing to deploy solutions to remote areas, but it's another thing to ensure that the solutions are being utilized effectively by the recipients. And so with this then is a few examples, 3 of which I'll provide in terms of some of the initiatives that we are taking to ensure that solutions that are deployed are of good quality and are able to fit the needs of the people that they are intended to serve. So the first aspect has to do with the question, how do we ensure that digital solutions deployed in remote areas, in urban areas, are carrying the appropriate WHO standards and guidelines? And so what we're seeing here is a roadmap of the digitalization of WHO products. And this initiative is intended to ensure that the guidelines that WHO produces, usually in text form, are converted into a manner that people that are deploying digital products are able to consume these guidelines immediately within the digital health products. What we're dealing with here is really converting the narrative guidelines, which are usually in continuous narrative form, into a package, a digital package, that implementers of digital solutions would be able to adapt immediately and directly into the solutions. And so this means that the quality of digital solutions that are out there would be improved in terms of the health content that they are maintaining, being informed by digital adaptation kits, as we call them, or smart guidelines, as we also call them. This is a critical area to ensure quality of digital health products in as far as the health content that these products are containing, but at the same time ensuring that where we have limited experts, especially in rural areas, the digital solutions themselves will be consistent with WHO guidelines. And this has been a major gap because the guidelines WHO has produced have tended to be narrative form, and implementers have tended to translate the guidelines manually into the solutions. And what that leads to is inconsistencies in terms of implementing digital health solutions. So we as an organization are developing WHO digital adaptation kits to ingest the guidelines into digital solutions so as to enable those people that may not be familiar with the guidelines to utilize the implementers' digital health products in a consistent manner. This is one area that is critical for us to ensure the quality of digital health products is maintained. And what you see here is a summary of what I just talked about, moving from the narrative guidelines and then creating mechanisms whereby we ensure that the guidelines are situated in an environment appropriately, but more importantly, making the machine readable so as to ensure that there's consistency in the implementation of digital health solutions themselves. Second is the low-hanging fruits that we see, especially in remote areas, leveraging mobile connectivity, especially feature phones and the opportunity that basic SMS provides. We have partnered with ITU and together internally with our NCD department to leverage connectivity and also SMS technology. And SMS technology has a promise to at least reach more and more people in remote areas, given the wider availability of mobile connectivity. With this program called the Be Healthy, Be Mobile program, we have steadily progressed in terms of providing a platform whereby people in remote places and also in urban places are able to receive targeted health messages. And these health messages currently are focused on non-communicable diseases, and we publish guidelines, and we publish handbooks, and within these handbooks, we have set the stage for our member states to consume research, based curated messages of high quality that are based upon research that are positioned to be channeled to health seekers using taking advantage of the mobile phones that they have access to. This is a promising area given the wide availability of feature phones and also given the increasing penetration of mobile connectivity. Now, lastly, I'll speak specifically around one of the areas that is critical towards improving access to health services. And this particular area, as reported in our last survey on e-health, pertains to the area of telemedicine. Now, telemedicine has been quite promising, especially in COVID times, to really make the access to health services more routine using the connected environment. Telemedicine has been implemented for the past 2 decades, but COVID-19 has taught us that there are opportunities that we see around leveraging the connected environment and really moving health services close to where people are. In our last survey, in 2015, we saw that at least more than half of our member states had a specific telehealth policy implemented. And at the same time that approximately 3/4 of our member states themselves had implemented one or more telemedicine programs like teleradiology and etc. The opportunity here is really leveraging the telemedicine programs and products that are out there to reach people where they are, especially those in remote areas. The challenge that we're facing around shortage of specialized manpower in remote areas can be mitigated by making sure that we are bringing the experts closer to the people in remote areas using an appropriate telemedicine, telehealth modality. The spread of telehealth modalities has been reported in our last survey to really be focused around those health services that are provided at tertiary level. But we see more and more interest for telemedicine to be implemented for primary health care services. And that's an opportunity that people in remote areas have access to. Now, when I say telemedicine, I was really referring to the ability to provide access to health services at a distance. And we've seen a number of examples. Our partners at one of our collaborating centers, the University of Geneva, have been promoting a program called the RAF Network, which has been deployed in several countries in the African region and other countries across the world, where we've seen tremendous uptake of this ability to provide care to people in remote places. The RAF network itself has been really focused on deploying telehealth services in remote places and using the telehealth platform to provide e-learning opportunities to increase the capabilities of those health workers that are in the remote places so as to enable them to deliver better health and care. We know that to do this, we need to leverage the different modalities in which telemedicine is provided. Stored forward modalities, which feature phones can easily do well, whereby an observation is stored and then transferred across a medium to an expert for interpretation, or interactive services that require continuous connectivity. And at the same time, remote monitoring devices are becoming more and more prominent, which enable people to monitor their care without the need to be connected to a connected environment. And so there are tremendous opportunities for us to leverage telehealth services, and much more importantly, to leverage telehealth services for primary health care purposes. What you see here is what was reported in the last survey, where different telehealth products and services were defined for tertiary services. And so we'd like to ensure that tertiary benefits of telemedicine are also implemented for primary health care purposes. Some of the key barriers that we need to address are issues of interoperability and data exchange, issues around the funding to make sure that we're able to stretch the implementations in urban areas to the rural places, and also making sure that we're promoting telemedicine as a means by which we can reach people in remote places. And so competing health programs normally pose as a challenge, but at the same time, we need to leverage opportunities that exist with the telemedicine modality. And with this, then, I would like to just conclude by saying that we have produced a number of guidance documents to ensure the consistent implementation of digital health solutions, depending on the setting that is being targeted. And so we recognize that to do these things, we need to address a number of items. And these particular items include ownership, making sure that governments are using national digital health strategies to identify those gaps where services are lacking, and using those strategies to expand the reach of services. And at the same time, we need to recognize that there is need for us to create this partnership around communities of practices, because there's more and more entities that are in this particular space trying to expand the reach of services using digital means, but addressing those key issues around data exchange, especially across borders. We also need to address the issue of capacity, especially capacity for health seekers in rural communities in terms of digitally being literate, and at the same time, capacity around the connected environment. And then lastly, I spoke a lot about low-hanging fruit around telemedicine. We see telemedicine as low-hanging fruit, especially for remote areas, because telemedicine indeed is health at a distance. With this then, I would like to conclude by saying, working together, we must ensure that the transformation of the health sector itself is equitable and reaches the people that are marginalized, and at the same time ensuring that this transformation is safe and sustainable and scalable. Thank you very much for your attention, and I pass the floor back to you, Theodora.
Thank you so much, Dr. Monin. You raised really important issues, and I was struck by the data that you shared regarding the growing gaps in connectivity and internet access in rural areas. The data that 72% of households in urban areas have access to the internet at home, almost twice as much in rural areas at 38%. And that with regard to connectivity gaps, specifically for mobile coverage. So where 17% of the rural population live in areas with no mobile coverage at all, and 19% of the rural population covered by only a 2G network. So I think you set your presentation against this backdrop, and then very succinctly drawed out how we can use partnerships and innovations in overcoming those key gaps and reducing the digital divide. So I think I'd like to just applaud you for what you're doing to push forward on this frontier. It's really the frontier of our times, and we want to make sure that we don't leave the rural populations behind, and that we can use this as a tool to actually improve their health and reduce the coverage gaps that rural populations experience. So thank you very much. I'd like to now go to our next speaker. So that's Dr. Stuart Keel. He's a technical officer within the Vision and Eye Care Program, Department of Non-Communicable Diseases at the World Health Organization headquarters. In his current role, he supports the implementation of the actions outlined in the 2020 World Health Solution Integrated People-Centered Eye Care, including preventable vision impairment and blindness. Teleophthalmology holds great potential to improve the accessibility of services in countries where geography, population, and workforce distribution make it difficult to provide specialist eye services outside of major cities. Ophthalmology is particularly suited to telemedicine due to its high reliance on imaging for the diagnosis and management of ocular disease. Dr. Keel's presentation will focus on engaging rural and remote communities through telehealth, a case example from Lions Outback Vision, Australia. So over to you, Stuart. Thank you for being with us.
Thank you very much, Theodora. It's great to be here with you today. So as mentioned, so today I'm going to focus on a specific case example that we put together for the WHO World Report on Vision that was published in 2019. And that case is looking at engaging rural and remote communities in Australia, specifically through teleophthalmology. And in particular, I just first wanted to set the scene for this, this discussion and this case example today by just looking at the health status and the eye health status of Indigenous Australians. And Indigenous Australians represent around 3% of the entire Australian population. And in general, this segment of the population experience worse health outcomes in general, and with eye health, this is no exception, and these disparities are quite marked. And from a recent epidemiological study in Australia, it was found that there were three times higher rates of vision impairment and blindness, 3 to 6 times higher rates of diabetes, and strikingly, about 1 in 10 Indigenous Australians with diabetes had very late stage diabetic eye disease, and were at risk of blindness really at any time. But the key statistic is with many of these eye conditions and causes of vision impairment is that the majority of the cases are preventable or avoidable through early detection in the case of, and timely management in the case of diabetic eye disease, but also many of the conditions can be corrected with a pair of glasses, or vision can be restored overnight with a simple and cost-effective operation of cataract surgery. But one of the key challenges to providing eye care in Australia is simply the gross size of the country. And as portrayed by the map on the right of screen here, we can see that much of Europe and the UK really fit very comfortably within the borders of Australia. So although Australia has a very, very high quality eye care services, there tends to be significantly lower levels of access in rural and remote areas when compared to major cities. And this is where the majority of Indigenous Australians reside, in fact, 65% or more. So we heard from Derek before that telemedicine in general, and in this case, teleophthalmology, really holds great potential to improve accessibility where these specialist services are difficult to provide outside of major cities. And as mentioned in the introduction, eye care is particularly suited to telemedicine, given there is a very high reliance on imaging, and for example, imaging of the back of the eye, of the retina using camera devices and so on, that are needed in the diagnosis and management of many ocular diseases. So this really brings us to the case example that I wanted to present today. And this is the case example of Lions Outback Vision. And this service has been provided as a statewide teleophthalmology service since 2011. And really it works by linking patients in rural and remote areas of Western Australia, which is the largest state of Australia, to consultant ophthalmologists and other eye care professionals in the major city of Perth, which is down the bottom here. And the distance from Perth to the furthest community which is serviced is over 3,000 kilometres, just to give you an idea of the scale. So the service itself in Lions Outback Vision has 2 key components, and the first is a telemedicine service, and this operates in combination by providing both an online booking system, or as Derek put it before, a store and forward system that where results of investigations and eye care investigations are uploaded to the platform where the treating eye care professional in the capital can review prior to a scheduled call with the patient. But there's also an on-call or urgent assessment system that's in place as well for urgent cases, of course, but also in cases where individuals have traveled a significant distance and it's recognised that it's unlikely that these individuals are going to have the opportunity to come back for a future appointment. So the referrals for this service come from a range of professionals and settings, and the primary eye care workforce in particular, which is optometrists in these rural communities, but also rural hospital emergency departments and also general practitioners in these rural and remote areas. And really there's marginal infrastructure costs to this service, or additional infrastructure costs to these services, because the video consultations are all done using existing platforms such as Skype and Facebook. So this brings me to the second component of the service, which is the outreach service. And patients who, after their telemedicine consultation, require specialist care are booked in for an appointment at an upcoming outreach visit. And these outreach visits are multi-pronged and consist of visiting primary eye care workers who really play an instrumental role in improving the efficiency of referral and more targeted referral to the specialist services, but also ensuring ongoing care following treatment at the specialist services. There's also periodic outreach specialist clinics that are set up in regional hospitals. And then there's also an Lions Outback vision van, and an image of this vision van is on the right of screen here. And this vision van consists of 3 consulting rooms, and it includes quite sophisticated equipment, and that enables the care of quite a significant range of common eye diseases such as glaucoma, diabetic retinopathy, and also trachoma, which is still present in Australia in particular. And this van completes a range of circuits around the state of Western Australia per year. In fact, it visits the 19 communities at least twice a year in its action. So this slide here just gives an idea of the workforce model that's in place. And it is a multidisciplinary model that includes the primary eye care workforce, which Australia is lucky to have in optometrists. It includes the general health services, that includes local general practitioners and Aboriginal health workers, and then it includes the specialist ophthalmology services. So just to say, however, that this has been an evolution over the years, and from the inception, as I mentioned, in 2011 to 2015, this service was primarily ophthalmology driven. However, due to successful advocacy and presentation of evidence, government health insurance rebates were introduced in 2015 to really support this telehealth service for optometrists for the general health services. And this has been successful in leading to, nearly over 90% of the primary eye care workforce in these regions now participate in the telemedicine service, which was a great outcome. So here we have presented the clinical pathway of the Lions Outback Vision model, and just highlighting where the efficiencies in access have been made in particular. So we have the teleophthalmology service down here highlighted in brown, and this really enables fast-tracked access to the specialist care highlighted here above it. So it does this in 2 ways. And firstly, it really, compared to the traditional referral pathway from the non-eye health professionals, the general health services here to the specialist clinics that were very congested. There was a long waiting time. It does this by diverting referrals from these non-eye health professionals to number one, the primary eye care workforce in the middle, which are able to manage actually a large number of eye conditions, and one of the most common eye conditions being refractive error, that don't necessarily need the specialist care. And then there is also a diabetic retinopathy, a tele-ophthalmology diabetic retinopathy screening centre that has been set up, where images are taken of the back of the eye, are sent to this reading centre in Perth, and only those cases in which that are identified to have vision threatening disease are then referred on to have an appointment with the specialist clinic in the outreach clinic. So the outcome of this has been that the specialist clinics can now manage very well triaged pathology, where injections and laser occur for common eye conditions such as diabetic retinopathy, and much of the other services then can be provided at the primary level. So this has also eliminated the waiting time before being placed on the waiting list for other surgeries such as cataract surgery, where there was a significant wait involved that I'll touch on in a moment's time. So now looking at the key outcomes of this service, and really one of the key outcomes of the telehealth service is that the non-attendance rate at the outreach visit has decreased from 50% to 3%, which is obviously quite substantial. Also, they've seen due to the on-call or real-time telemedicine service that has been put in place has led to a significant increase in the number of Indigenous patients now accessing eye care, and this has been a tenfold increase over the course of the period in which this has been implemented. And patients have demonstrated quite high satisfaction with this service as well. So I mentioned before the provision of these video consultations. They also have included getting patient consent and booking for other common surgeries such as cataract surgery. And this has really had significant outcomes, and it's eliminated the wait for the waiting list, where patients used to wait up to a year for a public service appointment prior to being placed on the waiting list for surgery. And also, as I've mentioned before, this video consultations have significantly, and this pathway of including primary eye care workers has really increased the efficiency and impact of the outreach services. And there is a much higher proportion of primary eye care being managed by the optometrist, and there's less duplication of services. But also there has been a marked increase in the surgical management by the specialist at these outreach appointments as well. So that is the case example that I wanted to present today, and just to acknowledge the driving force behind this work, which is Dr. Angus Turner, who is an ophthalmologist in Western Australia, who has been driving this initiative since its inception. And with that, I will pass back over to you, Theodora. Thank you.
Thank you so much, Stuart, for that very insightful case study. Excellent. I think now we are coming to the part of the webinar where we can have some Q&A. So I would like to please encourage people to jump into the chat if you haven't already done so, and put your questions in. And I know we have the webinar function where you won't be actually able to speak, so we really do require you to put them in the chat. And I would like to just start us off with one of the first questions that came through on the chat, and that is, what incentives have been given to primary healthcare providers during the project that we saw for the DORAD area, and is it sustainable? And so this is a question for Dr. Lakhabakasuren and Gambat. Please, over to you, either of you.
Thank you, Tia. Shortly, there was around $7,000 for each contractor. It was just to support initiative and catalyze their proposal to support other sectors to contribute in health sector and address the local issues in accordance with this multi-sectoral collaboration. The Health Equity Champion project was to support actually country learning on addressing equity in health, including working across sectors and healthcare service at the subnational level. In particular, there was interest in focus on health inequality caused by COVID-19 pandemic, and it would be useful if participants or contractor could build on existing and future work. So it will be supported by the state budget and support from other sectors on addressing on the existing and future challenges related to these equity issues. This project involved primary healthcare providers, as we mentioned, that is some health centers and family health centers, and they identify in topics they wish to work on and conducting the situational assessment, planning and implementing activities to address this topic. This process was supported by our technical and financial support, and we provided some advocacy and documentation and feedback, and we organized this 1 or 2 collaborative meetings where participants will develop the skills and learn from each other, plan, review, and reflect on implementation and contribute to the development of resources to help others do similar work. And in addition to that, with this last land area, Mongolia faces many challenges in delivering health services to disadvantaged and remote communities such as nomadic populations, migrants, and unregistered people, as we mentioned, and implementation of our project. One of the approach was using this mobile health technology through a primary healthcare approach is provided to be a low cost effective way to address inequities and ensure that everyone everywhere in the country can access the health services they need. So it is sustainable, and it could be continued by the state budget, and it's just motivate initiative of the local primary healthcare providers. Thank you. Over to you.
Thank you so much. Okay, so just going on to the next item that has been raised, and this would be something that any one of the panelists are free to respond to. So Teresa Zakaria has stated, sharing of information cross-border is indeed important. In many countries, border lines are not meaningful to communities who share familial and societal ties across the border. Healthcare is sought on both sides. So I'm just wondering if any of you want to speak at all to that issue. I think it came up a bit in the DORAD example of just people along border areas. But I'm wondering if any of the speakers want to talk to that. Okay, I don't see anyone. I can just say that using barrier assessment methods, I think it can be particularly relevant with communities in border areas to understand basically how they're accessing services and what barriers they may be facing in doing so, and also their perceptions on what services they would want to seek out that could then maybe on the other side of the border, indeed, the services that they would want to seek out because it's the closest area. And in that case, that information is useful to feed into cross-border planning by health authorities. Okay, and we have another just reflection coming from James Rook in Canada, and he states, cell phone technology seems to be leaping past formal telemedicine, and best examples are integrated into integrated digital health record systems accessible to both healthcare workers and patients. Does anybody any of our panelists want to touch on that item at all?
Yeah, Dora, I think Gumbat touched on, and I think some of the others touched on, I think Derek in particular touched on the difficulty with access sometimes to bandwidth and those issues. And I think the services in rural have to be adaptable. They have to be able to say, in this case, we might just use an ordinary telephone. In this case, we'll allow give our patients access through their mobile phones. So I think it's that adaptability that's so important in rural areas, that you have to use whatever you can and not be stuck with a particular technology. And I agree with Jim that the big, video conferencing screens and things like that really aren't very usable quite often in rural areas. They might be good in cities, as I think Derek pointed out, that sometimes where there's big technology and big bandwidth, some of those things can work well. But I wonder, Derek, if you've got any comments on that, about that flexibility of using various technologies, and even sometimes just good old telephone calls. We might have lost Derek.
Able to come in, or I think he may be having some connectivity issues. Okay. All right. Well, we also have a second question for him in the chat as well. So I think what we're going to do, just as we're not hearing from Derek, is get back to people. Vandra, we can answer your question via email in the follow-up to this. Okay, so we would like to now just move on. And Bruce, would you like to say some kind of reflections and closing words now? And then I'll do a little bit of wrapping up for the overarching series. Thank you.
Thanks, Theodora. I think it's been another excellent session. This is our last session in the webinar series. I think particularly Dr. Vasuran and Gambat, thank you very much from Mongolia, giving us I loved your idea of local needs, better solutions, and being able to get out to the people in the remote areas, the really doubly disadvantaged. Often they're living in a remote rural area, but they're away from the health service. And I think the adaptability you had with taking technology to them in an effective way was just terrific. And I was very, very pleased to see that it was based on primary healthcare and family practitioners. Too much of the time, there's a service that comes in and doesn't use those practitioners, and I think using those is excellent. And I think Stuart also showed how that can be built on as well. I think not only was it a visiting service and a telehealth service, but the thing I really liked, Stuart, about what you talked about was that the local services, be it the primary care doctors or the primary optometry practitioners, could have a key role in delivering those services. And I think that's the secret about visiting services, is they must enable the services there rather than duplicate the services that are there. They need to build on the primary care that is in those communities already. Derek talked a lot about, as we just mentioned, the bandwidth and the access, and the irony that the telehealth connectivity is best sometimes in a urban area where there is access already. And so having that adaptability is just so important. And as Jim pointed out, using whatever technology there is. So I think building on teams of generalists, we're very keen to see family doctors with broad skills. We're keen to see nurses with broad skills, community health workers with broad skills, and then having these services come in or beam in to both assist the work that's done by those local practitioners, but also help those local practitioners with the knowledge from the specialties in their practice now. That's the beauty of actually working in rural areas these days. I know myself, I can just go straight onto the internet and get some expert opinion to assist me in my decision making at a local level. So I think certainly those technologies have assisted very much in the modern world. Just wanted to quickly overview the last series that we've had, and it's a bit of a thanks really to Theodora in particular for what she's done over this time. I just wanted to take us through the series that as we've had, and Theodora will talk in a moment about how we'd like to build on this and present it further. But I think the key topics that we've had over the last few months are particularly important in rural areas. The lessons of rural proofing, the strategies, plans and programs, and Ian Cooper, who's on tonight, is doing some important research around rural proofing and how our younger generation, the future generation, see that rural proofing being important to their future careers. We've also had a very powerful session on Indigenous populations and their needs. And we've heard in a number of our talks that some of the most disadvantaged are the native or Indigenous populations all around the world, and getting services to them that are effective in their communities. The continuing issue of rural workforce, and particularly gender equality in that workforce, and the being, I think, equitable pay and equitable chance for people of both genders to be able to participate in the workforce and obviously in their own health. We had a really fascinating session with the FAO and others about the agricultural sector, and I think the ability of the agricultural sector, if it's strong, to provide a good, healthy environment, good, healthy diet for people, and making sure that is enabled in rural areas. They've got great potential, but often disregarded. We then talked about information systems, and I think WHO has done some great work in this, and we had some exemplars of the big data being able to be used to assist in planning for rural areas. We looked then at some of the health inequalities and multi-dimensional poverty, and I think that's unfortunately a characteristic of many rural areas around the world, in lower and middle income countries in particular. We celebrated rural women around first of all in the previous one with the workforce around Rural Women's Day, and then Women's Day this year, and looked at those inequalities. And then tonight to have the innovations discussion. Unfortunately, our speaker from rural Wonca couldn't be with us tonight because he was actually involved in a crisis in his community and helping his community. So we're very sad that Morad couldn't join us tonight to also give a local clinician perspective. But really, a big thanks to WHO, to the Director General's office, and particularly to Theodora. And I'll just hand back now to Theodora to look at the road forward from here. And thanks to all our participants, thanks to all our speakers, and we look forward to working with you further. We've got our conference in Limerick coming up in June. And we're looking forward to some of you being able to get to that conference to talk about these matters in the rural context. So back to you, Theodora. Thank you.
Okay, thank you so much, Bruce, and thank you for the great partnership throughout this whole series and enabling the Wonca perspective to consistently come in. I have some closing words. Thank you so much, Pramila. Next slide, please. I think across this whole webinar series, we've really aimed to look at different entry points for tackling rural health inequities, acknowledging that they are the result of adverse social and environmental determinants, as well as weaker health systems in rural areas. And so here you see in this slide the different, the sides of the different dimensions for health system strengthening, and our webinars, as Bruce has outlined, has touched on multiple of these. And then on the other side, we have, the cross-sectoral work to address determinants. And again, while our webinar series touched on these a little bit less, it still did touch on multiple of them, gender equality being one, non-discrimination, and rural proofing particularly stand out. So this is work that WHO is keen to grow over this forthcoming period. Next slide, please. And we very much look forward to partnering with you all. And I'm just going to tell you about some of the forthcoming activities that we have. As Bruce has indicated, there is the overarching Wonca World Rural Health Conference that's happening in Limerick, Ireland from the 17th to the 20th of June. I encourage you to go and look at the website. I would definitely hope that we can take some of the findings from this webinar series and feed that in. We have submitted an abstract which would consist of a cross-analysis of the more than 40 presentations from all of the speakers through this series. And we would share that at the conference. Then we're also working on a special edition for rural and remote health on rural proofing and health. And we're partnering with OECD, Wonca Center for Rural Health, Stellenbosch University, as well as the Pan American Health Organization, WHO AMRO, and Wonca. And here, as Bruce also mentioned, we are getting the insights as well from young people, and there will be a forthcoming Rural Seeds Cafe for the Southeast Asia region that will feed into this special edition. It's the last in the rural cafes, as they've been covered, they've covered all the different WHO regions, but this is the last one coming up. And if you're interested, please do let us know, and we can make sure to contact you with Stellenbosch University, who's organizing that, so that you can participate. Then OECD and WHO are jointly organizing a roundtable on rural proofing and rural health at the OECD Rural Conference in Ireland on the 28th of September in 2022. And then we are further developing an online scenario-based learning session on tackling health inequities in rural areas. And this will be part of a forthcoming WHO course on primary healthcare. And we also have ongoing work, for example, in the occupied Palestinian territories now, and as well as some countries in the Americas, on support to national authorities for conducting assessments of barriers to health services experienced by populations in rural and remote areas. And we are making sure that we mainstream a rural focus and overarching gender equity, human rights focus through our normative work on barriers. Next slide, please. So as was mentioned earlier, the whole series can be accessible through our online web portal for the series. So you can go and you can access all PowerPoints, all recordings if you want to, to take advantage and use these recordings, for example, in trainings that you're running, please do so. And then these are also double posted on the Wonca website for those of you who are attending from Wonca. And I just wanted to really thank the Wonca Rural Working Party for excellent collaboration. I'd also like to thank OECD for a couple of the series editions in this series. We have partnered with them for getting speakers, and they've also come to speak on their different pieces of related work. Different UN agencies from the Inequalities Task Team Rural Inequalities subgroup have joined us as well and helped us to identify speakers. And so I'd like to thank them. And then multiple WHO colleagues across the 3 levels have joined. For example, we have our Mongolia country office and other departments today, and just thank you very much for that. And as well, of course, to the speakers who have come from member state national authorities and subnational authorities for their great inputs and insights. And just finally, a word of thanks to my own colleagues in the GER team. So Pramila Shretha, who's been a backbone for organization of this series, as well as Susana Gomez, who was very much part of the earlier editions in the series, Claudia Quiros and Anne-Marie Cavillon, who have been covering the communications, and of course, Erin Kenny and our Assistant Director General, Similela Nono Sinelela, for their great contributions and support across. So on that note, I would like to thank once again the speakers from today for very insightful and interesting presentations, and we do look forward to further collaboration with all of you moving forward. And I thank you for your commitment to this topic. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Thank you very much. Bye-bye.
Thank you.
Thanks so much, everyone. Bye-bye.